it's left here, so 12 o'clock, 3 o'clock, and 6. So as I said, there is a history of head trauma a few months ago with immediate conductive hearing loss, and we have now this dislocation of the incus, which is not anymore connected to the stapes, which seems to be intact. So of course the plan will be to do malleus-to-footplate reconstruction rather than TORP, and I use TORP with silastic bending and malleus relocation. Crochet pour le canal de la corde. So I need to do the body rim resection first. So we'll. Pardon?
Why is your preference the TORP rather than TORP?
You know, in the past I was always using TORP. And then I had cases where it was already always recurrent dislocation of the TORP or tilting with a lack of efficiency, and so I just wanted to improve that. And there was a paper made by Moretz from the US, Curet, who was saying that he had better results with TORP rather than TORP, despite the presence of stapler large. So I was interested in this, and then of course I introduced first the malleus relocation technique, which allows for better placement of TORPs or TORPs, by the way. And then I tried, and I had better results. And then I introduced the silastic bending technique, which of course made a huge difference in my result, in my hand. And so I was able to compare prospectively my results between TORPs and TORPs, and could see that I had much better results with TORPs and silastic bending, of course. And I published this in Otology Journal, comparative series, and then I turned up to TORP in all cases now. And it works better because with the silastic bending we have we decrease the tilting, of this.
That's the problem with the TORPs, is stability.
Sure. Yes, sometimes they're still on good position, but if you move them, they move separately from the stapes. And so, but the new one with the quartz made or Medel, they're looking good. But I have this experience now, and I'm just. Donnez-moi encore la curette. I'll reduce a little bit more the body rim. I'll increase a little bit more the body rim here. Resection, because I'm going to relocate the malleus, so I don't want to have the neck of the malleus becoming in contact with the bone. All right, so we have a nice view here of the dislocation again. You see that here with some fibrous tissue still connected to the stapes, but and if I move, of course, the malleus, we have not any more movement with the stapes. It's completely disconnected. Okay, ciseaux there. So I will first separate incus from stapes. There we go. And now I'm going to dissect. I'm going to check the stapes. It's good to do it now. Calmez, s'il vous plaît. I'm sure the stapes is very mobile. So I check it always from the top of the head, and you see it's completely mobile. And a nice round window. Okay, so what I will do, because I do the silastic bending, so I'm going to cut the tendon, of course. Ciseaux. Ciseaux.
Does it matter where you cut it?
Well, it needs to be long enough to stabilize the bend. Okay, like this is enough. Because I want to place the bend underneath. Canley. 3 de chou, pardon. Because it helps for decreasing the risk of lateralization of the bend. Ciseaux encore, s'il vous plaît. There we go. Okay, Canley, encore. I need to be sure that there is a gap here in which I can place the band. Yeah. Yeah, it will come anyway. There is still some adherence between the incus and the stapes. You see these fibers? Okay, that's fine. Alright, now what I need to do is to dissect the malleus, preparing the malleus relocation technique. I keep the incus in place for the moment because it helps. It gives some resistance when you do this. And do the calmer manger marteau, s'il vous plaît. Alright, so we're going to work on the malleus now. Okay, the cord is there. C'est un 12 hein, que vous m'avez donné là.
No, it's too long.
Table en avant, s'il vous plaît. Stop. Okay. Calmer manger marteau. Alright, so I'm always starting with the incision through the periosteum of the malleus all along like this, and then elevating. Did you try already the malleus relocation, or
I haven't done the malleus relocation.
not yet? Again, it's a nice technique which helps a lot for any prosthesis placement because you don't care anymore about the position of the malleus. You change everything and then you adapt it. And it's an easy technique, it's not a major problem. The only issue is the umbo,
Yes.
because it's really attached to the malleus there. So sometimes there's a risk of making a tear, but it's always a limited one. So it doesn't create much problem there.
Okay.
And the other problem that some people say is that there is a higher risk of lateralization, but I've never had lateralization due to malleus relocation, really. It's always related to another cause, like the previous patient we did with a total tympanic membrane perforation. So I just follow the bone all around like this, and I think it's fine. Calmer manger marteau encore. But I will check the tympanic membrane right after that to see if there is any tear or not. Go to the short process, and then because you need to entirely separate the malleus from the tympanic membrane like this. Okay, let's check that at tympanic membrane, which is fine. There's no problem with that. Okay, good. So now I'm going to remove the incus. Crochet à os, s'il vous plaît.
I think definitely makes it more stable and leaner.
Yeah, sure. It helps. Okay. Some people may use a cement there to reconnect incus to stapes, but I don't think I don't think it's going to work.
No, I think I was talking to John Hamilton about this. He said
Yeah,
that over
yeah.
time it cracks and it just doesn't.
Yes, exactly. That's what I think the same. Yeah. Okay. All right. Now we have the second step, which is cutting the tympanoid tendon lancéolé direct. And then you see the gap that we have between the malleus, which is really anterior here, and the stapes, probably because the stapes was partially dislocated, maybe posteriorly, I don't know. But
Oh, I see.
so if you leave it like this, then of course it's difficult to place the prosthesis between the malleus and the stapes. You have to bend the prosthesis, and it's not good. Crochet à os. Okay, so I'm going to relocate the malleus now by overstretching the anterior ligament. So you need to place the hook anterior to close to the neck like this, and then you pull the malleus posterior until you reach the resistance of the anterior, which is there.
Yeah.
And then you put a sucker on the other side to control the mobilization, and then you pull until you break or overstretch the anterior ligament like this. Okay, and it needs to be a really complete relocation, allowing you for
It goes back to
a nice placement now. You have already just the malleus overlying the stapes footplate, which is perfect. And it's also good for PORP, because then you have a direct connection. I know that also many surgeons would say, we don't need the malleus, we keep it the malleus anteriorly, and we put the prosthesis directly underneath the tympanic membrane. But I believe that it is more stable if you use the malleus.
Okay.
Calmez. C'est bouché. Oui, c'est bouché. Okay, so what I need to do now is to measure the distance from malleus to footplate. And the major point is to be sure that we are measuring from the right position. You can see there is a medialization of the malleus. So you need to stick it back. Crochet, s'il vous plaît. A little bit more than this. So I'm going to pull a little bit more, okay? Like this. Just... Yeah, you need to be sure that it's going to be in contact. That's it. Okay, that's a good position now. Okay, and now I can measure. Mesureur, s'il vous plaît.
I guess you need to put the prosthesis on this side away from the facial nerve.
Yeah, but I will see. I show you. La même que tout à l'heure. Oui, c'est un 5-8 et il me faut la même prothèse que tout à l'heure.
C'est pas un 5-8,
Ah ben, non. Le normal, c'est que pour l'enclume. Okay, so I'm going to measure, because I think I will put the shaft there, because there is a gap here. So, and I don't want to put on the other side, so I put it here. So what I'm going to do, I'm going to touch the full plate and then measure the distance. There we go. And you see the lower one is there, which means 5 millimeter. So it's not going to be a very long one. I will cut it at 5.5, okay? Because I always add 0.5 as usual. Bon, canne les manches du marteau encore, s'il vous plaît.
Does the nerve ever get in the way? Do you ever...
The nerve, no, doesn't make any problem. Even if you have a contact between the facial nerve and the prosthesis, it's not that problem. What I will do, I will cut it a little bit more than 5.5. I will cut it at 5.75. Un 9, s'il vous plaît. Non, j'ai pas besoin de gabarit.
Non, non, oui, il faut les garder.
Un 9, s'il vous plaît. Pourquoi vous les gardez?
Monsieur Dumont, il s'insère des fois pour...
De prendre des sizes.
Ah oui, je comprends.
Aspi.
Oui, aspi.
Il faut prendre ça des fois.
Okay, there's a good condition here. All right. Okay. Okay, this is the prosthesis again. So I need to put at 5.75, which means 4.75. So this is 5.75, okay? And then I will put it at 4.75 first, and then pull it back. Merci. Là, c'est bon, ouais. « 5,75. Okay, that's fine. Pince. Micro-pince.
Does the band move up and down the shaft, or does it stay in a fixed position?
No, you can move it up and down. By the way, I'm going to move it a little bit lower. Pince droite, s'il vous plaît, sans griffe. You can take it like this and then pull it a little bit lower or up according to what you want. I think that's fine, which is a good thing. You can really adapt it, and it's very flexible. You see, compared to the previous one that we did ourselves. All right, so yes, double vers moi. Yeah, it was difficult. Stop. So the trick here is to put the shaft between the facial nerve and the anterior cruce and see if we can deal with this. So I'm going to check. On the other side, I can put it also between the promontory and the stapes superstructure if necessary. So I try first here and see what I can do after that. Okay? And do, s'il vous plaît. Right.
75 normalement.
Okay, it's not easy to place it, so I'm going to place it separately like this and then see how I can do it. Okay, good. Table en avant, s'il vous plaît. Stop. Calmez. C'est un 12 hein, qu'il me faut là maintenant. C'est un 12, d'accord, ça va. Alors c'est bon. Ok. So I'm going to use my right hand to help the placement. So it looks good, you see how it's mobile. So now what I'm going to do, I will introduce the malleus within the groove. But to do this, I need to pull the malleus and rotate the prosthesis head. Okay, just like this, then we'll move later. Crochet, main gauche. And it goes very well. You can rotate it, and now it fits very well. So we could leave it like this. But I want to ensure the stability with the bend. See if I can do it, because it's not so easy to make it now. Because there is a gap, you could see that. Can you mange du marteau d'abord? Okay, allez, 3 de choc. Alright, so I will probably temporarily dislocate the prosthesis in order to try to place this band around the stapes, but I'll see how I can reposition the prosthesis after that. This is not an issue. So I need to grab the band and take it and put it around the stapes head. You can see how flexible it is. But of course, it's pushing the prosthesis posteriorly. Now it's fine, you can see.
Yeah.
It's underneath the tendon. Canley. So, canley normal. What I want to do now is to try to see if I can find a best position of the unit. And of course, the band is moving posteriorly. So see if I can move the shaft. Well, I think it is fine now. You see, they are moving together just like a single unit. No more. There's no risk of tilting with this technique. The only the cause of failure with this technique in my hand was more related originally to short prosthesis, which means that I was making a mistake at the beginning to measure. So what we need to do now is to reposition the drum and to see if everything fits well without any tension or any other problem. Okay? So we do this, stay in place. You can see here the position. And if I re-elevate, everything is fine. Okay? Good connection, good stability. Alright then. Looks good.
Make it look so easy.
It will come. Merocel, s'il vous plaît. Silastic bending merocel is a tricky technique. It's a difficult one. But malleus relocation helps a lot because in this case you recreate the point of stability by placing the malleus, using the malleus. You have 2 points of stability then. And with the TORP, it's the same thing. And when I designed this prosthesis, I designed it with Grace Medical because I wanted to have a groove in the center of the prosthesis head, which also makes a difference. Makes a difference. Okay, that's fine.
Great, thank you.
Tu peux arrêter, Véro?